Yes,
Okay,
ma'am.
so good evening, everyone, and thank you so much for joining for today's webinar series. Today's topic is on the diagnostic approach of genetic disorders, which will be presented by our esteemed speaker, Dr. Manisha Goyal, ma'am. We welcome you, ma'am, for today's session and to enrich us with all the information that you could provide us. Just a small background about Dr. Manisha. She's done her MBBS, DGO, and PhD, and currently working in the Department of Medical Genetics in the J.K. Lawn Hospital in the SMS Medical College Jaipur. Uh, and she's also worked previously in the Medical Genetics Department of the Gangaram Hospitals, and a lot of other things to add into her uh, achievements for sure. And then she's trained in the CDFD lab in Hyderabad also. And the key interests are in the birth defects, dysmorphology, intellectual disability, and the inherited metabolic disorders. She's a member of multiple esteemed uh, organizations across the India and also published multiple book chapters and publication in the national and international journal. With no further delay, I welcome you, ma'am. I'm sorry to cut short your introduction a little bit less, so please start off the session.
Yeah, thank you so much, Kriti, for my introduction. And I would like to give thank you to the ORDI team and the organizers who gave me this opportunity to share my thoughts. So, we are going to start with my topic, diagnostic approach to genetic disorders. So, sorry, it does not.
We can see your slide, but it's not moving yet, ma'am.
Yeah, actually. So what should I do?
Ma'am, can you just like go back and then reshare the screen? That would help mostly. Maybe
Okay.
it's stuck. We can see your screen now, ma'am. Yes. Yes. Works.
No, I think I need to put in a smaller version because it's not going.
Yes, we can see this moving,
Yes.
ma'am.
So is it okay?
This is okay. If you can just slightly and increase the screen size, ma'am, then everyone can see it also, maybe.
Yes.
Yeah, that should be okay.
Is it okay?
Yeah, ma'am, it's visible.
Okay. Yeah, I'm so sorry for this trouble. So, as we all know that genetic disorder is a disease which is caused by a change in the chromosome or a DNA which is away from the normal sequence. So we can say that the genetic disorder are caused by mutation in one gene or multiple genes or by damage in the chromosome or by combination of gene or environmental factor which is called multifactorial disease. So we can say that the genetic disorders can appear at any age, but most of the disorder, like around 80% of the genetic disorder manifest in the childhood period. So we can categorize the genetic disorder into three major groups: single gene disorder, chromosomal, or multifactorial. So you can see here that we all know that in every cell there is a nucleus, and the 23 pair of chromosomes are present in every nucleus. So when we unwrap the chromosome, it is basically deoxyribonucleic acid which is wrapped over the histone protein, and a specific part of a DNA which can code for a protein is called gene. So a gene is a functional unit of DNA which can make a protein or enzyme or a functional part of our body. So, a disease which is caused by DNA mutation in one specific gene is single gene disorder. So, this defect alters or stop the protein formation and resulting in the symptoms manifestation. So we can classify single gene disorder into Mendelian disorders or non-Mendelian disorders. So in the Mendelian disorders, autosomal recessive disease, in the autosomal recessive disorders, parents are carrier, and for the disease manifestation, both copy of the gene should be affected, and there will be 25% risk of recurrence in further pregnancy in the autosomal recessive diseases. And the next is autosomal dominant disease, where one functional copy of the gene is responsible for disease manifestation, and there is 50% recurrence risk. Then X-linked recessive disease, where the affected gene is present over the X chromosome, and the usually manifest in the males, and the females are carrier. X-linked dominant disease, which manifest both in the males and female, and the males are severely affected. And then the other category is non-Mendelian disorders, including mitochondrial disorders, triple repeat disorders like Fragile X, Huntington's, genomic imprinting disorders like Prader-Willi, Angelman, Beckwith-Wedman, etc., and the disorder which is due to gonadal mosaicism. Then come to the chromosomal disorder. Chromosomal disorders divided into two main groups: structural disorder or numerical disorders. So in the structural disorders, there may be deletion in the chromosome, means loss of a part of a chromosome called deletion, or duplication means presence of extra copy of a segment of chromosome is called duplication, or there will be inversion, ring chromosome, isochromosome, or translocation under the category of structural disorders of chromosomal issues. Then the numerical abnormality divide into two groups: polyploidy or aneuploidy. So in the polyploidy is basically addition of one or more complete haploid, for example, triploidy or tetraploidy. And aneuploidy is a loss or gain of one or more chromosome, including trisomy. We all know about the Down syndrome. So Down syndrome is come under aneuploidy, trisomy 13, 18. And then monosomy means the absence of one chromosome. For example, Turner syndrome, which is 45XO. Then other categories: multifactorial genetic disorder, where the combination of the genetic mutation or environmental factor is responsible for disease manifestation. For example, neural tube defects, diabetes, or heart problems, or many cancers. So come to the diagnostic approach to genetic disorder. So here the list of the headings which we are going to discuss. So first is suspicion. When we need to suspect a genetic disorder. So a child which is coming in our OPD with congenital malformation, at least one major or two minor anomaly, we can suspect the genetic disorder. Dysmorphology means different or unusual from parents, come under the category of genetic disorders. When there will be growth deficit like short stature or failure to thrive, or when there is a developmental delay or developmental regression, then we can suspect the genetic disease, or when there will be mental deficit or intellectual disability, or when there is failure to develop secondary sexual characteristic or abnormal genitalia. So in all these category, we can suspect a child with genetic problems, and need to need to take further step. So uh, For these kind of patients or children, we start with history, including antenatal history. We have to take history of mother age at conception. This is particularly important for the chromosomal aneuploidy. For example, we know that Down syndrome risk is increased with the advanced maternal age. Then we have to take history of fever with rashes, because this is important for the intrauterine infections like CMV or rubella. So we need to take history of fever with rash. Then ask about the USG abnormality if it was present in or diagnosed with the sonologist, the amount of the liquor, or there was any history of preeclampsia or chronic maternal illness such as diabetes. Ask about the fetal movement, like decreased fetal movement is usually present in the neuromuscular disorders, or if there is a active, more active fetal movement. Then ask about the history of any exposure of medication like valproate. If the mother was taking excess amount of the valproate, then there will be chance of fetal valproate syndrome. Or if there was any history of tobacco, alcohol, or any chemical or X-ray, MRI exposure, then we have to take all the history for our children diagnosis. Then come to the perinatal history. Ask about the duration of labor or difficult labor. So it is very important because most of the cases of GDD or seizures or spasticity are diagnosed with the CP, cerebral palsy. So this history is very important for such kind of patients. Then mode of delivery, or as I told that the history of birth asphyxia, and ask about the neonatal problem like sepsis, hyperbilirubinemia, or hypoglycemia, because in these cases also there will be developmental delay or seizures in a child. And if the parents were not able to give any history, then see the natal medical records. Then ask about the postnatal history. If there was any significant problem in the neonatal or the postnatal period, like jaundice, vomiting, tachypnea, seizures, or there was any abnormal posturing or spasticity, any vision or hearing problem, then ask about all the history. Then come to the medical history. So, for the genetic disorders, we have to take the three-generation family pedigree. It is very important. As I told you, that we can classify the Mendelian disorders into autosomal recessive, autosomal dominant, or X-linked recessive disease. So, with the family history or family tree, we can think about the inheritance pattern. Ask about the consanguinity, because the autosomal recessive disorder, the history of consanguinity is very important. Ask about family history of mental retardation, developmental delay, any history of seizures in any family member, or unexplained psychiatric disorders. If such kind of history is present, just see the records, or if possible, examine or investigate the affected family members. Then ask about the history of congenital malformation and a stillbirth, miscarriage, or early childhood death in previous pregnancy. And then come to the developmental history. So we have to take the developmental history, including motor milestone, fine motor or gross motor, social or language development history. Then, if the parents are giving history of developmental delay, then please be sure whether it was developmental delay or the developmental neuro regression. So it's very important for many kind of neurometabolic disorders of this neuro regression history. Then come to the physical examination. So after taking complete history, we have to do examination. So start with a complete anthropometric assessment, including height, weight, head circumference, upper segment, lower segment ratio, and put into the graph. So we can take the centiles or standard deviation for the age appropriate charts. Then detailed dysmorphological evaluation from head to toe. This evaluation is very important for the diagnosis of genetic disorder cases. Then do the detailed neurological evaluation, including higher mental function, cranial nerve deficit, motor and sensory motor examination, cerebellar sign, and respiratory system per abdomen or CNS examination. So these are the few pictures of dysmorphic evaluation. You can see here that this is a smaller Yes, I this is called microtia. So this is second degree microtia. This is third degree microtia. And you can see here the facial features, facial dysmorphology is present. That here the periorbital puffiness is present, the broad nose, lower thick lip, and on the examination there was heart defect. So we can suspect the a genetic disorder with the facial features and other findings. And you can see here the this broad philtrum and thin upper lip, and there was many other features in this child, and this child was diagnosed with a carbamazepine teratogenicity. Here the specific facial dysmorphism is present, so we can diagnose a few of the cases with this facial dysmorphism. You can see here the micro retrognathia. This is cleft palate, and you can see here that this child was presented with failure to thrive. You can see here this bird-headed face with a prominent nose. So it's a significant finding in the Seckle syndrome. And in this figure, there is post-axial polydactyly. So, if this post-axial polydactyly is isolated and no other developmental deficit is present, then it can be a isolated finding, not a genetic problem. So in this case, you can see here the skin hyperextensibility. So it's a major feature of Ehlers-Danlos syndrome. You can see here the woolly hair. So this kind of hair is present in the Mankey-Kenke syndrome. And you can see here this absent nail. So absent nail developmental regression and developmental delay, and many features are present in the Coffin-Siris syndrome. So this absent nails is a clicking point for the Coffin-Siris syndrome. So many of the syndrome has a clicking sign. So you have to take the proper dysmorphological evaluation and take a clicking point. And here you can see this syndactyly in the second and third toe, but in this child, no other features are present. So it's not a major finding for the any genetic disorder. So uh, this syndactyly can be present as a isolated finding. Then ophthalmological examination is also very essential part in our genetic diagnosis. You can see here, this is a corneal haziness, also called as corneal clouding. And in this case, there is a cataract, bilateral cataract, congenital cataract. So this corneal clouding can be present in lysosomal storage disorders such as mucoliposaccharidosis, oligosaccharidosis, or mucolipidosis. So whenever a child come to you with a coarse faces, that hand contractures or the abdominal distension, hepatosplenomegaly or hernia, along with this corneal clouding. So you can suspect the cases of MPS. Then if the congenital cataract is present or liver manifestations are there, then you can think of galactosemia. Or but this cataract is also a feature of congenital rubella syndrome, congenital myotonic dystrophy. Then dislocation, lens dislocation is a feature of homocystinuria or Marfan syndrome. So many of the cases are referred from eye department with the lens dislocation. Then we have to make a diagnosis of genetic condition. Then retinal changes and pigmentary degeneration are a feature of Bardet Biedl mitochondrial disorders, or sometime in the intrauterine infection. Then cherry red spot is a feature of storage disorders such as Niemann-Pick or gangliosidosis. So eye evaluation is very important part in our genetic diagnosis. Then come to the baseline hematological and baseline investigations. So start with the CBC, as microcytic hypochromic anemia along with the hepatosplenomegaly may give clue of the thalassemia, or the macrocytosis is give clue of the vitamin B12 metabolic disorders. Then RFT, LFT, and of course serum CPK is a major finding for the muscular dystrophy cases. And thyroid profile, it's very important in the cases of intellectual disability or mental retardation cases. So we have to do this thyroid profile in all cases. Then a specific test which is based on the clinical features, like if any child come to you with a developmental delay or seizures, then you have to do EEG. Or any child if giving the history of Gowers sign or the muscular problem, then do the EMG for the muscular dystrophy or myopathy changes. If there is a hypotonia or the absent DTR, then please do NCV for the neuropathy like SMA cases. Then audiometry, it's very important in the cases of speech delay or no speech or hyperactive behavior cases. Then ultrasound to look for the renal malformation, as many of the genetic syndrome has a renal malformation. For example, Towns-Brocks syndrome, it's a facial findings along with a thumb anomaly or renal or imperforated anus. So ultrasound sonography abdomen is also important investigation in our cases. Then of course echocardiography in all the facial dysmorphic cases for the cardiac malformation. For example, Williams syndrome or the Noonan syndrome. Here, the aortic stenosis or pulmonary stenosis give us clue for the diagnosis. Then come to the neuroimaging. So neuroimaging MRI brain is recommended when there is abnormal head size like microcephaly or macrocephaly, or whenever there is a history of seizures or focal motor or neurological findings or neurological examination, or when there is a feature suggestive of associated craniofacial malformation. Then MRI brain is preferable to CT scan for the neuroimaging, and it is much more informative. And CT scan, of course, it is better for the intracranial calcification. For example, if we are suspecting the congenital CMV cases, like if there is a cataract or there is a seizures or spasticity, or there was a history of fever with rashes, then we have to think about congenital CMV, and intracranial calcification give us clue for the this CMV. And tuberous sclerosis, CT scan is better. And for the craniosynostosis cases, yes, CT scan, 3D reconstruction skull is better than MRI brain. So the neuroimaging also has a specific part in the diagnosis. Then come to the genetic evaluation. So a question arises, why genetic testing is required in all the cases? Because it is essential for the confirmation. A positive result can direct a person toward available prevention, monitoring, and treatment option. And very importantly, a negative result can eliminate the need for unnecessary checkups and screening tests. Because if child remains undiagnosed in the genetic cases and they are roaming here and there, one pediatrician, another pediatrician, neurologist, and they are doing battery of the investigations before the confirmation. So, by genetic testing, we can confirm and eliminate such kind of unnecessary checkups and tests. And of course, for the management, also genetic testing is required. For example, we are doing newborn screening for some places in India. So, by newborn screening, we can identify the genetic disorders at earliest. So, the management can be started as early as possible. And of course, wherever the treatment is available, for example, few of the LSD, like Gaucher disease or MPS, ERT is available. So we can give the ERT after the confirmation of such LSDs. And of course, the prevention. So many of the pediatrician ask me, if the treatment is not available, why you are advising this genetic test? So my answer is for the prevention. So we can exclude the risk of recurrence by prenatal testing. So this is very important, very, very important. So you have to counsel the parents if this child is first or second, and they will plan for another pregnancy, that if we are confirming the diagnosis in this child will give risk of recurrence according to the autosomal recessive dominant or X-linked inheritance, what will be the risk of recurrence in the further pregnancy, and will do prenatal testing by CVS or amniocentesis in the further pregnancy. So, when to recommend a genetic testing? So, pediatrician, neurologist, or any geneticist can recommend a genetic testing for a child who ever experiences developmental disabilities or delay in the motor, speech, or cognitive function, or any child presented with structural birth defects, or if there is a chronic functional problem in vision, hearing, neuromuscular affective disorders, seizures, behavioral or mood problem, then we can advise the genetic testing. So we can categorize the genetic testing into three main category: cytogenetics, molecular or biochemical testing. So I'm giving the brief detail about these testing. So cytogenetics is basically the study of the structure and property of the chromosome, and methods which we are using under cytogenetics are karyotype, fish spectral karyotyping, and microarray. So the sample, what are the sample which we can use for the chromosome? So this is very important that we need the live dividing cell for the cytogenetic study, such as blood, bone marrow, skin fibroblast, tumor cells, or we can do the chromosomal study over amniotic fluid, chorionic villi, sample of the placenta or fetal blood for the prenatal cases. So come to the karyotyping. So karyotyping means the counting the number of the chromosome which is present in a specified number of cells in the metaphase spread, and the pictorial diagram of this chromosome is called ideogram. So this is a picture of ideogram, and you can see here the chromosome number 1 to 22, and then XX or XY. This figure is called ideogram. So what are the indication for karyotyping? So whenever a child or anyone is present with a multiple congenital abnormality, you can advise a karyotyping. Or when there will be unexplained intellectual disability with or without malformation, or disorder of sex development, or whenever a girl present with primary amenorrhea or infertility, or a female with recurrent abortion, then we can advise a karyotype, because in the infertility or recurrent abortion cases, balanced translocation may be a cause of this kind of problem. Or if there is a prior history of unexplained stillbirth or neonatal death, we can advise the karyotyping. Or whenever parents of a child with a structural chromosome and abnormality, we can use this prenatal testing for the prenatal cases, whenever ultrasound abnormality or abnormal biochemical screening is found in the antenatal cases. Or for the malignancy and chromosomal breakage disorder, we can advise the karyotyping. So these two images are showing the chromosomal problem. Like you can see here, there is 22 chromosomes are normal, but there is only one X chromosome. So means this is 45X, so which is called Turner syndrome. And in this case here, you can see this 21 chromosomes copy are 3. So this is Down syndrome or trisomy 21. Sorry. And then come to the fish fluorescence in situ hybridization. So this fish is a cytogenetic technique that uses fluorescent probes that bind to only those part of a chromosome with a high degree of sequence complementary. And in this cases, we study this fluorescent probe DNA complex under the fluorescent microscope. So I'm not going into detail of the procedure of fish. I'm going uh, next is, the application of fish is the identification of a specific chromosomal abnormality, like microdeletion syndrome such as Cry-Duchet, Williams syndrome, Angelman, or many more. And to identify the origin of a marker chromosome, to delineate a breakpoint of a chromosomal rearrangement, to detect low level of mosaicism, study of the telomeric region, chromosomal abnormality in the cancer, monitoring the success of bone marrow transplantation. So these are the application of fish. And fish is also used in the research purposes. For example, the identification of new non-random abnormalities by Fisher Sky for gene mapping, identification of region of amplification or deletion by CGH, identification of translocation breakpoint, or the study of 3D chromosome organization in interface nuclei. But there are some limitation of the fish also. like fish pro are only available for the well characterized deletion and duplication syndrome, and it does not screen all the chromosome for changes. So we can use fish only in the cases where we are suspecting a particular syndrome. Like if I'm seeing a patient in OPD with a facial dysmorphism or the cardiac defect and I'm suspecting a Williams syndrome, then we'll advise the fish for that Williams syndrome. And fish has limited ability to precisely define which genes are involved in an imbalance, and it can be difficult to see a duplication using fish, as the attachment of extra probe is not always easy to see. So fish is used for particular microdeletion syndrome. Then this is a spectral karyotyping. It is a cytogenetic technique which is used to simultaneously visualize all the pairs of chromosome in different colors on the same platform, which is very easy to detect numerical and structural abnormality of all chromosomes. So it is a recent development in fish and can be used to study the whole genome. So here you can see this is the normal spectral karyotype, and all the chromosomes are colored in a different color. And here you can see this three blue color are present. So this is case of Down syndrome. And this spectral karyotyping is basically we used in cases of the marker chromosome. Like in a normal karyotype, if we detect one extra chromosome and we don't have any idea of the origin of the chromosome, then we use this spectral karyotyping to paint the same color of that a chromosome origin. Then it is used basically that spectral karyotyping is used basically for the translocation or other structural abnormalities, and it is useful for identifying the complex chromosome rearrangements found in many tumors. Then what is the difference between karyotyping and fish? So by the karyotype we can scan all 46 chromosome in one test, and by the fish we can scan only the targeted region, because it's a probe based technique and turnaround time of the karyotype is around 10 to 12, and fish is very fast, around 3 to 4 days. Karyotype is cost effective, but fish is high, not very much cost effective. The disadvantage of karyotype is the low sensitivity for the micro deletion and time consuming. And by the fish, we can use this technique for the micro deletion, and it's a faster technique. Then come to the micro array. So the principle of array CGH is basically comparison of the patient's DNA with a control DNA sample, and to identify the difference between the two set of DNA. In this way, deletion or duplication in patient's DNA can be identified. So this is a technique. Here you can see here the patient DNA and the control DNA are mixed here, and a particular array chip are there, and the hybridization with the hybridization, if the equal hybridization is present, means the normal array report and no deletion or duplication is detected in the patient sample. But if there is doses loss, means there is deletion, or if there is doses gain, means duplication. You can see here this part is the deleted, which is figured here as a red, and this green color is a gain. So we can use the blood sample for the array CGS, as well as we can also use this saliva sample or stored DNA from the previous test for the array CGS. So the main advantage of array CGS is the ability to explore all 46 chromosome in a single test and to detect any DNA imbalance, including extra or missing chromosome and loss or gain of chromosome material much more precisely than the conventional chromosome analysis. This can detect the chromosomal imbalances when there are no clue to what the chromosome anomaly might be, and so would not be detected by performing specific genetic tests such as FISH. Means if a child come to our OPD with a developmental delay or facial dysmorphism, and we are not sure which kind of chromosomal aneuploidy or the chromosomal imbalance is there, so we can advise this array CGH, and it can reveal which specific genes are included in the deletion or duplication part, as the labs are giving a deleted or duplicated part, and we can explore the genes which comes in this deleted or duplicated area, and we can see the function of that particular gene. So these are the advantages of array CGH. So what are the indication of microarray? So as I told that we can use this array for the multiple congenital anomaly, which is not specific to any known genetic syndrome. If there is a developmental delay with facial dysmorphism, or if there is unexplained developmental delay or intellectual disability, or we can also use this array CGH for the autism spectrum disorder, as many of the study are suggesting that ASD can be associated with microdeletion or duplication disorders. Then, what are the limitation of array CGH? So, this CGH cannot detect the balanced chromosomal rearrangement. It will also not detect some type of the polyploidy, such as triploidy. It cannot detect the point mutation, and the main point, it's expensive. So here you can see that this is a uh, chromosome number one. So the major part of the chromosome is called karyotype. Means we can see here the structure of the chromosome in neck dye in this figure. So by the microarray, we can see the mirror image, means the higher resolution image of that particular area of the chromosome is called a microarray. Then come to the molecular test. So these are the different type of molecular test: PCR, polymerase chain reaction, MLPA, multiplex ligation probe amplification, sequencing, and next generation sequencing. So PCR is an in vitro technique for the amplification of a specific sequence of DNA, which is used for further testing. PCR we are using for diagnosing inherited disorders such as cystic fibrosis and thalassemia. So, we talk about 10 years back period, we were using PCR very frequently for the common mutation of many conditions like for thalassemia, cystic fibrosis, Delta 508, or many more. And but nowadays, we are not very frequently using this PCR because we have more advanced technique with a less cost. So PCR we are usually using for infectious agents like torch infection, HIV, or torch. And in the forensic cases, PCR is used for the forensic analysis of DNA sample and DNA fingerprinting. But the PCR has a limitation because it needs prior information about the target sequence to generate the primers that will allow its selective amplification. And we can use the dry blood, semen stain, vaginal swab, ear, fingernail, buccal swab, or skin for the PCR. So you can see here this one image of the PCR I have taken from my friend from molecular lab. So this part is empty, means there is a deletion of this area. Then come to the MLPA, multiplex ligation dependent probe amplification. So MLPA is a multiplex assay to detect copy number variation of genomic DNA sequences. And in MLPA, this sequence of interest, the so-called target sequence is amplified, but a probe that hybridized to the target sequence, typically within an exome. So main advantage of MLPA is that we can detect the copy number of 40 to 50 genomic DNA sequences simultaneously, and it allows the study of several regions of human genome in a single reaction. and it is a budget friendly test and technically uncomplicated method. So we are very frequently using this MLPA for diagnostic purposes and for the identification of healthy carrier in the cases of DMD, SMA, and Charcot-Marie-Tooth disorders. So in our practice, the SMA and DMD cases are very much common nowadays because of the increasing awareness. So here, a very important point that around 85 to 90% of the cases of DMD are caused by the deletion or duplication. So if you are advising a test for DMD, you have to write the DMD MLPA for 79 exons because previously the hotspot exons were tested by PCR method, but now we are using this MLPA for 79 exons for DMD. And also for SMA, first test should be MLPA for SMN1 or SMN2 gene. If they comes negative, then you have to advise for DMD gene or SMN gene sequencing for further confirmation. So here you can see this is a reference sample, and you can see here the peaks are there. And in this sample, there is a homozygous deletion, so peak is not there. And here also, this is a reference sample, and these are the peaks. And the peak size is less, means there is a heterozygous deletion in that particular ASPA gene. So this is a report of DMD patient. You can see here the exons are not there. There is no peak. Means there is a deletion of this exons 8 to 48 in the DMD gene. So this is a positive result for DMD cases. Then we are also using this MLP in prenatal diagnosis for the screening of aneuploidy of chromosome 13, 18, 21, and XY chromosome. So this MLPA is also very frequently for amniocentesis and CVS chromosomal testing. Then come to the methylation detection for imprinting disorder and epigenetic disorder. For example, chromosome 15 Prader-Willi or Angelman syndrome. We are using this MLPA methylation study. And the disadvantage of MLPA is that MLPA cannot be used on single cell. At least 3,000 cells are required. Cannot be used on the sample amplified by WGA method. It cannot detect a balanced translocation, and dynamic range of MLPA is limited. And the presence of mosaicism might go undetected by the test, as the presence of normal cells can mask the presence of abnormal cells. So these are the disadvantage of MLPA. Then you can see here the sensitivity rate of MLPA detection as for the DMD cases. We can detect the DMD in around 95% of the cases by this MLPA. In SMA, 95%. Charcot-Marie-Tooth duplication is present in 70 to 80% cases, and deletion in 85% of the cases. And for the Prader-Willi Angelman syndrome, methylation abnormality is detected in around 95% cases by MLPA. Then come to the Sanger sequencing. So sequencing is basically the process of determining the precise order of nucleotide within a DNA molecule. So we are using this DNA sequencing to find information regarding the gene mutation, identification of the polymorphism, profiling of the DNA methylation in the genome, identification of gene regulatory control sequences to determine the paternity of a child, or in cases of exome sequencing. So sequencing is nothing. It is basically the comparison of patient DNA sequencing with known gene sequences. As you can see here, this is a known gene sequences, means where are the ATCG series, and this is a patient DNA sequences where we don't know about the series of this ATCG. So you can see here, this is a known gene mutation, and this is a patient gene mutation. So here the G is present in spite of C. So this change is called mutation. We can detect this by Sanger sequencing. So this is a normal DNA sequences, ATCG series, and it is also present in our DNA library. Here, you can see here this red one. So this is called single base pair mutation. You can see here this part is deleted. So this is deletion. And these extra is present. This is called insertion. And here multiple red areas are there. So these are the multiple mutations like present in breast cancers or many other cancer cases. So Sanger sequencing we are using for a particular disease. Like if you are suspecting a case of a known syndrome, for example, achondroplasia or osteogenesis imperfecta, then you can advise a particular DNA. Like for achondroplasia, you can advise a FGFR3 gene mutation by FGFR3 gene sequencing. Then come to the next generation sequencing. Next generation sequencing do the massively parallel DNA sequencing technology, which has revolutionized genomic research, and it takes less time, parallel sequencing process, and it sequences thousands of sequences at once. So it's a newer technology. So this is the comparison of Sanger sequencing and next generation sequencing. In the second Sanger sequencing, we sequence one read per sample, but in the next generation sequencing, we do the massive parallel sequencing. In The example of the next generation sequencing is clinical exome or whole exome. So in the clinical exome, we do the gene panel for neuromuscular disorders, developmental delay, neurological problem, or congenital malformation. And in the whole exome sequencing, we do the sequencing for all the readable or exome. So it covers the exomes which can cause known or unknown disease. It cover around 25 to 28,000 genes. And nowadays, whole genome sequencing is also doing by many labs, which cover exons and intron area or cryptic area. So this is a report of NGS whole exome sequencing where a child was presented with multiple fractures. So we do the sequencing of COL1A1 gene, and it was present that pathogenic heterozygous mutation was there, and the child was diagnosed with osteogenesis imperfecta type 1 as the child age was 3 years and presented with multiple fractures. Then come to the biochemical testing. So biochemical genetic testing involve the study of enzymes in body that may be abnormal in some way, and biochemical genetic testing provide diagnostic and ongoing care for children, adolescents, and inherited metabolic disorders. So this biochemical testing is basically useful for metabolic disorders like any child presented with developmental delay, seizures, or the uh, mm, periodic illness is there, then we can suspect the metabolic disorder and do first with MSMS on blood samples or urine GCMS on the urine sample for the biochemical markers. And in the suspected LSD cases, you have to do enzyme analysis, which comes under this biochemical genetic testing. So, this is my presentation. Now we are going with few cases. This is a case which were presented with developmental delay and hypotonia. You can see here the facial features like upslant eyes, depressed nasal root, short nose, and microcephaly was there, and the hands was short and stubby. So we were suspecting in this case with Down syndrome. So, as you all know, this Down syndrome is basically the trisomy 21, means three chromosomes are present at 21. So, this that trisomy 21. And if all are involving, then please give answer. Investigation of choice in this case: karyotype, fish, MLPA, microarray, or exome sequencing. So in this case, the investigation of choice will be karyotype. So this is the image of karyotype where we detect this trisomy 21. Then this is a case scenario two. 1 year old girl was presented as with developmental delay and facial dysmorphism, and the antenatal and postnatal period was uneven to full, and presented with developmental delay, as this is a 1.5 year old girl, but sitting and proper neck holding was not there. You can see here the facial features: that deep set eye, arched eyebrow, microcephaly was there, flat nasal bridge, long philtrum, and a pointed chin. And baseline investigation was normal in this case, and 2D echography was suggested ventricular septal defect, and MRI brain was suggested white matter hyperintensity. So here, the case with developmental delay, facial dysmorphism, cardiac malformation, and the MRI abnormality. So multiple congenital malformation was there. So in this case, there was two diagnoses: chromosomal or molecular. But in this case, chromosomal abnormality may be possible due to facial dysmorphism, developmental delay, and multiple anomaly. So in this case, the investigation of choice will be microarray, because we are we don't have any confirmed suspected diagnosis, so we are not advising this fish, because fish is applicable only for the known microdeletion or duplication or known chromosomal problem. So in this case, the test of choice would be microarray. So in this case was diagnosed with 1p36 microdeletion syndrome, and here the karyotype was absolutely normal. So investigation of choice was microarray. Then case scenario three: 8 year old boy presented with difficulty in walking and difficulty in climbing upstairs, and he also had history of frequent fall and decreased strength. And the family history was uneventful. So you can see here this calf hypertrophy. On examination, the Gowers sign was there. So you can see here the pictorial sign of this Gowers sign. So in this case, the motor delay, calf hypertrophy, boy, and the Gowers sign. And on investigation, serum CPK was raised 8,000. So the child was male. So in this case, we were suspecting DMD. And as I told, MLPA 79 exons of dystrophin gene is indicated in the suspected cases of DMD. You can see here that this child was diagnosed with a DMD with the deletion of exon 51 to 55 of dystrophin gene. Then another case, this full-term male baby delivered to 26-year-old primary patients, and the child delivered with a multiple deformities and respiratory distress, as there was no history of tendency to fracture in the family, and no family history of any baby with a fracture at birth. And they belongs to a rural area, and where the ultrasound was not done at 18-20 weeks or further period, antenatal period. And on examination, we found that the child had low set ears, deep nasal bridge, bowing of lower limbs. You can see here, sorry, with the diaper, you can't see, and shortening of all limbs. So in investigation, you can see here the bowing of bones and the fracture at long bone. You can see here the callus formation and the fracture and decreased bone density. So in this case, there was history of fracture in the antenatal period. There was bony deformity, and the X-ray also suggested osteopenia. So this was a case where we can suspect the osteogenesis imperfecta. So here the gene sequencing or whole exome sequencing is indicated for the confirmation of diagnosis. So we send sample for whole exome sequencing and call A2 gene confirmation was available with this test. So we were able to make a diagnosis of osteogenesis imperfecta in this case. And here also, this was the first child in the family. So we were able to do prenatal testing in the further pregnancy to prevent the risk of recurrence for osteogenesis imperfecta in the next pregnancy. And this is another case that 2-year-old boy presented with seizures and developmental delay. There was no significant antenatal history, and the birth history was uneventful, and neonatal course was not very much significant. And on examination, we found central hypotonia, dystonic movement of upper limb, microcephaly, and the child had a poor response to light and sound. And on investigation, brain MRI suggested cerebral atrophy, and other investigation were normal. And the metabolic workup, including TMS, GCMS, was normal. So this child had global developmental delay with microcephaly and hypotonia. And as we were not able to make a sure diagnosis, so we sent sample for whole exome sequencing in such case. And in this child, there was a likely pathogenic homozygous mutation in STAMP BP gene, which is responsible for microcephaly capillary malformation syndrome. So, with all these cases, my take home message is please do genetic testing in every case uh, because we need genetic confirmation for the management and for the prevention. So, we can say that no child deserves to suffer from disabilities and defect, and we need to aware physician, pediatrician, and obstetrician about myth of genetic etiology. And more importantly, newborn screening is necessary to prevent morbidity and mortality, and prenatal testing is necessary to prevent risk of recurrences. Always make a clinical diagnosis in all cases and send sample accordingly. Because nowadays I'm seeing that many of the pediatrician, physician, or obstetrician are sending sample for whole exome sequencing because that private labs are giving the whole exome sequencing testing and counseling in very much low cost. But before sending sample, we need to make a clinical diagnosis whether we are sending accurate investigation. For example, if the child is having chromosomal aneuploidy or chromosomal microdeletion and we are sending sample for whole exome, it is not correct. So the clinical diagnosis is must, and accordingly we need to send sample for appropriate testing. And importantly, pre-test counseling and post-test counseling is important part. So genetic testing should be voluntary because it has benefits as well as limitations and risk. So with this, thank you so much. Thank
Thank you
you.
so much, ma'am. Yes. So I was just that I think that you ran through everything from the basics of genetics to the complicated cases very well in a very nice, smooth flow also. Definitely our participants have got a clear insight on uh, what test, when to be done, and what are the algorithm of molecular and cytogenetic testing to some case examples as well as the background nitty-gritties of the test and the dysmorphology also you touched. We got a flavor of all of that. So, ma'am, we have a question from the participant.
Yeah.
So the question is, what is a compound mutation? How many government labs working on diagnosis which genetic disease more common you see in your center? So the three questions. So basically, what is a compound mutation? How many government labs working on diagnosis, and which are the genetic diseases that you see more?
Okay. So the first question is, what are the compound genetic mutation? So, as we all know that we have 23 pairs of chromosome and every chromosome has multiple genes. So, we have two copy of each gene. So, for the autosomal recessive disorders, we need the mutation in both the copies. Okay. So, if we have a particular gene mutation in both the copies, like C.190, to G mutation in both the copies, this is called homozygous mutation, means one type of mutation in both the copies of gene. Okay, but if the exon position is different in both the copies of the same gene, this is called compound genetic mutation for the autosomal recessive disorders. Okay, and the second question is which genetic labs, government genetic labs are doing genetic test free of cost. So this question is basically very complicated, and because in India most of the tests are doing in the private labs only. Few of the tests are offering by AIMS Delhi, like they're doing karyotype, or I don't know, because I am working in SMS Medical College, so here we are doing the karyotype, and we have this GCMS machine which we are using for our the high risk cases. It is not available the free of cost for all patient, but in future we have a proposal where government will support us genetic test by providing the instruments. But nowadays I'm working in SMS Medical College, and it's a biggest medical college or pediatric center or the department of medical genetics in the Rajasthan. But here also we are not doing frequently free of cost genetic test here also. And the third question, sorry, third question was.
Genetic diseases do you see more commonly in your center?
Yeah, so in our OPD, like I'm working in pediatric hospital, so we have the multi-specialty OPDs are there. Like we have that nephro, gastro, cardio, and the general pediatric OPD. So with the increasing awareness of the genetic disorder nowadays after COVID, I realized that I'm seeing more the Down syndrome. Every pediatrician nowadays can diagnose the Down syndrome. So we have a lot of Down syndrome. Daily 3, 4 Down syndrome are there. Surprisingly, DMD patients. So DMD patients are a big number in our day-to-day OPD nowadays, and SMA also, of course. So SMA, DMD. A big number here, and osteogenesis imperfecta. I don't know, maybe because of increasing awareness, like we are saying one or two osteogenesis imperfecta cases in our OPD, achondroplasia, very common, or I'm feeling that neurofibromatosis, NF1 cases, big number of NF1 cases are in this year. So, SMA DMD, yes, of course, I can see increasing number in our pediatric OPD. Yes, different kind of patients are referring to our department from ortho, from many specialty. But of course, this DMD, SMA, and metabolic also we are seeing in newborn high risk cases. Okay.
Thank you, ma'am, for that. We have another question also from another participant. It is for a family with a father who's having single gene mutation and the mother is 41-year-old. Is PGTA and PGTM both are recommended for the next pregnancy or the next child?
Yeah. If the father is having a mutation, so first we need to see whether it's pathogenic or uncertain significant, whether it's producing symptoms in father. So we have to be very clear about the pathogenicity of gene before doing the prenatal or pre-implantation genetic diagnosis. Yes, of course. M for the molecular testing, which the mutation is present in the father. Yes, we have to do. And this A aneuploidy, of course, with the advanced maternal age, we need to do this A also. Both the tests are required, but my suggestion will be if they are planning for IVF, then you can advise the PGD, MNA, because as per a newer recommendation, PCPNDT Act or this IVF guidelines, if you are advising this PGD M or A, and if the embryo is unaffected, then also we need to do chorionic villus sampling in the antenatal period. So this point should be clear to the parents before opting the PGD.
Any more questions? Nothing on the chat box, ma'am. So I think, yes, we have comprehensively covered it all again, ma'am. Thank you so much for your insight. If there's any other question, okay, there is one more question. Doctor, sorry, we missed this question, although you partially had answered it. When will SMS Medical College start newborn screening? So, what do you do?
Okay, so actually in 2016, we were doing the NBS for five common disorders: hypothyroidism, G6PD, CAH, um, and this galactosemia. But due to the shortage of funding, uh, we had to stop with the COVID also. But of course, that government of Rajasthan is taking initiative to NBS program here. So this is in the pipeline, and very soon it will start in the Rajasthan, this newborn screening.
Yeah. Okay. Think that's all, ma'am. No more questions yet. So, can we, are we done? Are we having anything else? No, no other questions.
Yeah,
Okay, ma'am.
thank you
So
so much,
thank you
Kriti.
so
Thank
much,
you.
time. Thank you, ma'am. Yes.
Yeah,
If there are
thank you,
any other
Auditi, for
questions, we'll all write to
giving.
you. Yeah.
Yeah, please mail me or just message me. I will be very happy to give answer. And thank you so much, Kriti. And thank you, Auditi, for giving me this opportunity. Thank you so much. Bye.